Scuba diving. Scuba, self-contained underwater breathing apparatus. Diving is a popular recreational activity with an estimated 2.5 to 3.1 million certified divers. The scuba diver who dives underwater poses a difficult diagnostic dilemma for investigating authorities and pathologists. The investigation should be thorough and follow a standard outline. The investigation should include the victim past medical and social history, diver profile, a detailed history of the terminal event and resuscitation effort, environmental condition, examination of the diving equipment, and finally the autopsy. Okay, the utility of going to the scuba death scene not only involves examination of the body, but merely important interfering and impounding all scuba gear. Just one more the picture. Scuba diver who has just recovered from the water. This driver's weight belt was tied in a knot around his waist because the safety buckle did not work. Inventory the equipment and photograph it preferably where it is still attached to the victim. A visit to the death scene or at least the board deck is helpful for the purpose of documenting and gathering all the diving equipment. The cylinder's air valve should be closed at the scene to prevent air loss from the tank. Not all scuba divers die from drowning. Image 9.29 coronal section of the brain. With a large intracerebral hematoma, the brain belonged to a 37-year-old scuba diver who was discovered on the surface of the ocean. Incoherent, his left side was moving and decaying, but his right side was immobile and limp. He was admitted to the hospital and died 2 days later. This is a case where the autopsy is helpful in determining the cause of this driver's sudden incapacitation and death. Several medical conditions, especially disqualification from driving, coronary artery disease, especially if the patient has had recent angina or previous MI, is one which a condition with its risk of sudden incapacitation by severe chest pain or rhythm disturbances. Approximately 10 to 20% of scuba dive facilities involve individuals with a severe coronary artery disease. Other conditions that normally disqualify a person from diving include seizure disorder, recurrent episode of sickle cell disease, insulin-dependent diabetes mellitus, the presence of pulmonary cast or blub, severe chronic COPD with bullous emphysema, spontaneous pneumothorax, and certain middle ear problems or surgery. Temporary disqualifying conditions include pregnancy and abdominal wall or inguinal hernia. Barotrauma is a tissue injury caused by failure of a gas-filled cavity, equates internal pressure with the changes in ambient pressure. The anatomic regions most commonly involved are the sinuses, middle ear, and lungs. Barotrauma of the lungs produces life-threatening extra-alveolar air syndrome. Extra-alveolar air syndrome can cause death or unconsciousness and subsequent drowning during ascent while breathing compressed air. The scuba regulator normally delivers air at ambient pressure and lung volume remains constant regardless of the depth. However, if you hold your breath or close your glottis during a hasty or panicked ascent, then the obstructed alveoli will overexpand from Boyle's law and burst, the air dissecting into the pulmonary interstitium. Air can enter the pulmonary cavity, pneumothorax, mediastinum, pneumomediastinum, pericardial sac, pneumopericardium, subcutaneous tissues or pulmonary veins. Air that enters the pulmonary veins can embolize to the coronary or cerebral artery air embolism, gas embolism. Radiography or computer axial tomography can assist in diagnosing extra-alveolar air in the pleural or pericardial cavity or intravascular location more easily than the standard postmortem examination. Image 9.37. Okay. Shows a left pneumothorax on chest radiograph. Shows air in the subarachnoid space in cranial CAT scan. Both imaging study came from a 20-year-old man with no scuba diving training or experience who joined his 3 friends for a day of scuba diving. He was found unresponsiveness and transported to near a hospital where these imaging studies were done prior to his death. Scuba diving equipment is examined in less than 25% of fatality, but this examination is as important as the other investigation. The following procedure should be done with the scuba equipment. Immediate gather and inbound all of the equipment. Inventory the equipment. If possible, photograph of the victim with the equipment still on prior to removal. Record the final tank pressure and close the air valve to prevent the air loss from the tank. Check the tank and regulator for defect. Check for a weight belt if 1% weight if it available. Record the condition of the buoyancy compensator. Is it inflated? Is it filled with water? Have the equipment examined by an unbiased knowledge diving expert who will provide a written report. Have air samples from the tank tested for correct partial pressure and presence of toxic gases. Have the internal lining of the tank inspected for corrosion. Image 9.32. Visual inspection of the second stage of this regulator involves a tone diaphragm or valve. Examination of any computerized equipment carried by the deceased diver can be critical to the death investigation. A diver who died of air embolism used a Datamax Pro computer console during his dive, which provided important information about the diver. The computer console indicated a maximum depth of 34 feet and a total bottom time of 7 minutes. The large number of triangles underneath the number 34 indicate that ascent was very rapid and in excess of 120 feet per minute. The recommended ascent rate is under 60 feet per minute. Panic in this inexperienced diver led to rapid uncontrolled ascent and fatal barotrauma. Pneumothorax is one example of barotrauma. Different methods are available for demonstrating a pneumothorax at autopsy. For instance, one can use an Erlenmeyer flask assembly. A large Erlenmeyer flask is partially filled with water. 2 hole stopper plugs the opening of the flask. A glass tube is inserted into one of the holes until it ends within water. The other end of the tube is connected to a large bore needle or trocar by elastic tubing. The other hole is left open. When the trocar enters a cavity with the air under pressure, air will bubble in the water contained in the flask. One can also use the time-honored water in flank pocket, because outlined by this scientist as seen in image. If the pneumothorax is large and under tension, one can hear an audible hiss as one first cut into affected pleural cavity. This will be overlooked if some other than the pathologist eviscerate the body. Radiography or direct observation of frothy air-filled intracardiac blood test identifies air emboli in the heart, and the heart is first excised. Examination of the heart or other blood-filled organs for air emboli while underwater is impractical and a bloody mess. Air bubbles in mesenteric and subarachnoid veins are non-diagnostic. Do's and don't. Perform a complete postmortem examination on all bodies recovered from the water. Remember that the postmortem findings in drowning are not specific for drowning. Don't forget that blood can leach from large wounds in a body recovered from the water, making the determination of wound vitality difficult. Forget to impound all the scuba equipment in scuba death and have the equipment examined by an independent knowledgeable expert. Fail to consider arterial gas embolism in the sudden death of a scuba diver. Thank you.